Hello, everyone, and welcome to the Parkinson's Foundation Expert Briefing. I'm Dr. James Beck, Chief Scientific Officer of the Parkinson's Foundation, and it's a pleasure to have you with us today. And today's briefing, which is one that I think a lot of people look forward to, will gain a deeper understanding of how medications work, their intended benefits and common side effects. We'll also address the natural progression of Parkinson's and the changes in medication regimes that may be necessary over time for some individuals. But before we get started, like we always do, I'd like to understand who's joining us today. We'll launch a poll that just should appear on your screen right now. And if you're on Facebook Live, please respond in our comment section because you won't be able to answer this poll. But we want to know, are you a person with PD or are you a care partner? Do you have a family member with PD? Let us know your background and who you are as part of that. We want to know what your best connection is to Parkinson's disease. And then we'll close the poll in just a little bit as part of this process and just see where we stand for who's joining us today. We've got a lot of people in here, and not surprisingly, again, a lot of people with Parkinson's disease. Good to see some family members or those children of those living with Parkinson's disease, as well as some healthcare professionals joining us. So that's fantastic. So thank you, everyone, for sharing your connection to Parkinson's disease. Always good to help ground this as part of the process. And before we begin, I'd just like to take a moment to introduce the Parkinson's Foundation. We are a nonprofit organization that is dedicated to improving the lives of those living with Parkinson's by enhancing care and advancing research. Our efforts are truly deeply rooted in collaboration with the Parkinson's community, ensuring that everything we do aligns with your needs and your priorities. So today's program is an excellent example of how we're working with you to meet those goals. So one of the things that we're doing is investing in breakthroughs, and PD generation is a key aspect of that. The foundation itself has invested nearly $500 million in research and care to improve the diagnosis and treatment and scientific breakthroughs for those living with Parkinson's disease. PD generation is forefront as part of that process, and it offers free genetic testing and counseling to those living with Parkinson's disease. Practically everyone in the Western Hemisphere, certainly within the US, PD generation is available to you if you have a diagnosis of Parkinson's disease. So we encourage you to share this opportunity with your community, and I think together we can make a difference in Parkinson's disease. And as a reminder, we're going to record today's expert briefings. So the recording will be available online shortly. So there's no need to check back to see if it's posted. We'll email you a link to let you know when the recording is available, as well as some other resources that are going to be covered in today's expert briefing. So for everyone who's registered, that will happen. And if you're joining us via late, you'll really be in for a treat as part of that process. And I'd also like to thank our sponsor for today, UCB Pharmaceuticals. They are supporting the mission of the Parkinson's Foundation with a generous grant, educational grant to support our expert briefings. So thank you very much to those at UCB. And we're honored to welcome our expert presenter for today's webinar. I'm really pleased to introduce Dr. Danny Bega. Dr. Bega is a neurologist who specializes in movement disorders and directs the Parkinson's Disease and Movement Disorder Center at Northwestern in Chicago. He also leads clinics focused on Huntington's disease and Wilson's disease, and he's deeply involved in clinical trials. In addition to his clinical focus on PD and other movement disorders, Dr. Bega has a strong interest in integrative medicine, where he brings a whole person approach to patient care. He also serves as the Neurology Residency Program Director and helps shape the next generation of neurologists training at Northwestern. Dr. Bega, thank you for joining us today.
Thank you so much for having me here. I really want to thank the Parkinson Foundation and everybody who put this talk together today. I'm just going to share my screen here. And so I've been asked to cover what I think is a pretty big topic today, Parkinson's Medications 101, and really with the objective of providing some education about Parkinson's medications and their use, but also giving a flavor for the entire trajectory of the disease and where these medications fit in. So I think that's a big topic. Here are my disclosures. And here are the objectives. It's really to try to cover a lot of information, and we have a big audience today. And I know that people are going to be coming at this with a lot of different experiences. And I'm hoping to provide some foundation for everybody who may be at all different stages or caring for someone at all different stages of the disease. I want to give you some insight into where medications fall into the spectrum of the disease and their pros and cons and the benefits and some of the side effects of medications. I want to talk a little bit about Parkinson's disease and how it evolves over time, and give you some expectations for what medications can do and what they can't do. And in that regard, where a comprehensive approach to care fits in as well, in managing the disease beyond just medications. Hopefully, this will set the stage for you to talk to your healthcare provider about your own individual care. Today will serve as general information. Certainly can't provide individualized information, but that is something that you should work with your primary neurologist on in terms of individualizing your personal care plan. This is not meant to serve as individual recommendations for any one particular person. So Parkinson's disease is a neurodegenerative disease that affects people, particularly as they get older. Although we know there's a spectrum of ages where people can be affected. But what happens in Parkinson's is um, uh, a constellation of different symptoms, which include movement and non-movement related symptoms. And in this puzzle you see here, Parkinsonism is highlighted. That refers to the motor symptoms of Parkinson's disease, things like tremor, stiffness, slowness of movement, trouble with walking. That's what we refer to as Parkinsonism. But you also see all these other words here that refer to some non-motor symptoms, mood symptoms, cognitive symptoms, fatigue, lightheadedness, all these different components of the disease. And what this is showing is that it's a snowflake disease, that people with Parkinson's disease all experience different combinations of symptoms, different severities of symptoms, and their progression will be different. And the components you see here in the picture will all actually vary from person to person. So we really need to individualize and tailor treatment, but we need to focus on all these different aspects of the disease as we do that. And we're going to spend most of the time when we talk about medications, we're going to be talking about the motor features, the Parkinsonism, but I will bring in some of the management of some of the other features as well. At the core of Parkinson's disease, we think about the neurotransmitter dopamine, and we know that the area of the brain where dopamine is produced and released is affected in Parkinson's disease early on. And the depletion, the loss of dopamine and the inability to release dopamine normally leads to the movement symptoms like tremor and slowness and stiffness and walking problems. Dopamine is an important chemical for that. And so as we think about medications to treat the movement symptoms, dopamine is going to be at the center of that story. When we think about what is the goal of treatment in Parkinson's disease, we wish that goal, and the Parkinson's Foundation and all of the doctors that are involved in managing Parkinson's and all the scientists and researchers are working on a way to stop it, to slow it down, to end the disease. But the actual practical goal day to day today in our clinics is to improve symptoms and to improve quality of life. Um, that what that means is that if there's actually no significant impact on quality of life and no significant disability, we at times may consider not treating for certain people for a period of time. We may think more about clinical trials to try to involve people in trials to try to slow down and one day cure the disease. And we'll focus on lifestyle-oriented things like exercise, rehab-oriented services, and education, like what we're doing today. But in terms of our arsenal of treatment options to manage symptoms and to improve quality of life, we have a lot of medication options listed here under the pharmacological therapies, with levodopa at the top and many different classes of medications listed beneath, as well as medications for non-motor symptoms. Then we have non-medication options, which are important at all stages of the disease, and then advanced therapies, which I'll talk about a little bit as well today. Um, I'm going to set the stage for the categories of Parkinson's severity, in my opinion. And what I'm going to give you is really variable and not meant to be a template for every individual person, but it's my experience as generalities of where people fall into and the terms I'm going to use. So very early, this is my term. I think of this in general as people, 5 years before the disease may be diagnosed, up to 5 years after the disease is diagnosed. And again, these asterisks that I have here are meant to imply there's a lot of variability here with any of what I'm going to say. But I think of very early disease as having mild symptoms that don't impact daily activities, that may not need pharmacological treatment for the motor symptoms for some people. When I think of mild disease, I think about, anywhere from diagnosis to up to 10 years. Again, really, I'm giving big ranges on purpose because it's really different from person to person. This is where symptoms start to interfere with activities, and there's typically a good, smooth response to medications to help with those symptoms. And in my practice, when I think about moderate severity disease, I think about having inadequate or more complicated responses to simple regimens of medications, or to low doses of medications, narrowing of therapeutic windows. And what that means is that medications work, but for shorter or less sufficient periods of time as the disease progresses. Some disability can be accumulating, and balance and gait can become more impacted. And I think of that in general anywhere from 5 to 20 years into the disease. And then advanced disease, I think about as people are having more significant complications and fluctuations, freezing and falling when they're walking, often with more non-motor symptoms starting to become problematic, like sometimes even dementia. And that can be year 10 to more than 20. And so you can see I'm giving these big ranges because it really will vary from person to person. So as we introduce treatments to try to improve quality of life and improve symptoms in those different areas as the disease progresses, I mentioned dopamine is at the core of the motor problem. We know that there's a deficiency of dopamine release and an inefficient dopamine release that leads to the movement symptoms of Parkinson's disease. And so there are two main categories of drugs that are ways of addressing dopamine more directly. We have levodopa, which is actually turned into dopamine. And we have dopamine agonists, which bind to the dopamine receptors and sort of create effects that are similar to what dopamine would do. And so these are the main core ways that we manage the symptoms that we think are due to inefficient dopamine. And they work a little differently. In the dopamine agonist category, I have the examples are pramipexole, ropinirole, and rotigotine. And they can treat the different movement symptoms of Parkinson's, and for some people, quite well. But they do have side effects, and in some people, that can include sleepiness, dizziness, nausea, confusion, and importantly, impulse control disorders in up to 13% of people. And that can include things like spending money excessively, obsessively thinking about sexual thoughts, compulsive eating, gambling, things like that. So these are things we need to screen for and watch for in people on these medications. Um, with dopamine agonists, however, we have less risk of some movement side effects. Movement side effects that we typically think about things like dyskinesia. A dyskinesia is an abnormal increased movement of any part of the body that sort of looks like fidgeting, like dancing or restless looking movements of the body. And so we don't see quite as much of that with dopamine agonists, which is nice. But we do see some of these other potential concerns with some people. And so different people will tolerate these to different degrees. And we find that about 28% do stop these medications due to side effects. About 40% will need another medication like levodopa added by about 2 years. And so it gives you just a general sense of how well people do with them. And then if we compare that to levodopa is our kind of gold standard, and it comes in different forms. The main one we think about is Sinemet, which is a combination of carbidopa, levodopa. There's many other forms of levodopa. Levodopa is turned into dopamine. So it's always going to be the most effective way to treat the movement symptoms of Parkinson's because we think that those are due to inefficient release of dopamine. And we're replenishing that with levodopa. So it is known to be the most effective. And this is actually showing in this chart on the left, you're actually seeing improvement. The bars that are lower are better. And you can see that the levodopa bar is lower than the pramipexole bar. It's showing that in this particular important study, the levodopa worked better than the pramipexole, than the dopamine agonist in this case. We know it's the most effective at treating the movement symptoms. It can have side effects. Nausea is the most common one. Nausea is something that we can address in different ways if someone has nausea with levodopa. Sometimes taking it with food can help with the nausea. If we're trying to avoid taking it with food, sometimes giving it with more carbidopa can help with the nausea. Actually, the carbidopa that is in the carbidopa-levodopa combination is the component that actually helps with the nausea. And the word Sinemet actually comes from the Latin for no nausea. Sin emat actually means no nausea, and that's because of the carbidopa. So sometimes adding carbidopa can help with the nausea if that's an issue. The other side effect that we can see with levodopa is the dyskinesia, which is again those motor, restless-looking movements of the body that can occur from levodopa. And to address that, there are various things we can do. We can lower the levodopa to improve that, or we can try to treat the dyskinesia directly with a medication such as amantadine. And I'll talk about that in a moment. So with levodopa, you can see tolerability in general is actually better. Only about 2% stop it due to side effects. And in terms of benefits, you can see it's also better. About 15% need another medication added by 2 years compared to about 40% on dopamine agonists. So you can see some of the differences in the comparison and why levodopa remains and continues to be our gold standard way of treating the movement symptoms. Other classes of medications, just to cover some of them, we have a class called anticholinergic medications. The example is trihexyphenidyl or benztropine. And this is effective at treating tremor and at treating dystonia. Dystonia is like a twisting or a contorting of a part of the body that can happen sometimes. And while these classes are effective at treating those symptoms, they do come with side effects, particularly cognitive side effects that we worry about. And there's some increased risk of cognitive problems over time in people who are on those medications. And so for that reason, they're less commonly used. Another class are the MAOB inhibitors. This would include rasagiline, selegiline, and sulfinamide. And in general, we consider these a well-tolerated but pretty mild kind of medication for Parkinson's. It's not specifically adding more dopamine. It is slowing the breakdown of the levodopa and of dopamine overall. And so it can have a mild, small impact on the movement symptoms alone. It can also extend how long the levodopa will last. And so it can be used alone or in combination with levodopa. Generally well tolerated, but its effects tend to be fairly small, not as significant as the effects of something like levodopa. And about 70% need another medication by about 2 years, just to give you a sense of how, the effectiveness of it. There are other similar medications that can also extend the duration that the carbidopa-levodopa lasts. That would include the class called COMT inhibitors, such as entacapone or opicapone, and then another class called alpha, A2A receptor antagonists, and the example there would be istradefylline. Those are medications that are used to extend how long the carbidopa-levodopa lasts or the effects of the carbidopa-levodopa. Another medication I've listed here is amantadine. Amantadine is a medication that works a little differently. It blocks a chemical called NMDA or a receptor called NMDA that is an excitability chemical in the brain. And by blocking that, it can actually reduce tremors and it can also reduce dyskinesia, which is that movement side effect that you can get from levodopa. So if someone were to get dyskinesias or extra movements of the body from levodopa, but presumably need to be on the levodopa for the benefits of it, sometimes we can add amantadine to counteract the side effect of the dyskinesia. Amantadine does have some side effects itself. It can cause, in older people, particularly people over 75, there's about a 20% risk of confusion or hallucinations on it. And some people can get leg swelling or skin changes over the legs with amantadine. So I know this is a kind of a whirlwind of throwing out a lot of names of medications out there. And if you're not an expert in these medications, it can be hard to keep track of this. But this is just to kind of set the stage for the variety and flavors of medications and hopefully something you can talk to your doctor about. Um, with coming back to levodopa, again, the gold standard medication. I mentioned that it's the one that's most effective. It does have some side effects that we talked about, and particularly the dyskinesias that people sometimes worry about. And so the question I often get is it too soon to start it? If it's the best medication and everybody with Parkinson's is going to end up on some form of levodopa generally, is there a problem with starting it now versus a year from now? And the answer is really that it should be used when it's needed. When quality of life is declined or suffering, it will improve someone's quality of life and it can improve their symptoms. And so that's when it often should be used. And what's shown here is starting levodopa, at day zero in this graph compared to a year later. And what you're seeing here is that the group that starts early has improved motor scores and improved general quality of life scores for that whole year that they're on the medication compared to the group that's not on it. And then after a year, both groups go on the medication, and then they're pretty similar. You can see there's no real difference in the group that started a year later. The only difference is that they lost a year of some good benefit in that delay. And so the argument would be, you want that year to be a better year, then you may need to start that medication. If there's some suffering or some decline in quality of life that can be treated, then it ought to be treated. A year later, delaying starting and going a year later, you don't really see a difference. We do know that the severity of the disease itself is associated with getting more dyskinesias and more complications and having the effects of the levodopa last for shorter periods of time. It's not directly related to when the levodopa is started, that those problems are more related to how long someone has been on the medication because of how long they've had the disease. And at 5 years on levodopa, about 50% of people will develop some motor complications like dyskinesias and fluctuations in the effects of the medication. And unfortunately, by about 10 years plus, it's about 90% of people that will experience some of these fluctuations. But that happens regardless of when the levodopa was necessarily started. That is more related to how long and how more advanced the disease is in terms of how well the brain handles the levodopa. The dose required also is related. A higher dose of levodopa will be associated with a little bit higher risk of getting some of these motor complications. And then individual factors that again, it's an individualized disease. So the body size of the person, their genetics, their absorption of the medication, gender even can affect how sensitive someone is to the effects of levodopa, which is why you may be different from your friend or a colleague in a support group or in an exercise program that you've seen. You may be experiencing very different effects because of various factors like these. And it also turns out the majority of people, if you ask them, are you more bothered by the symptoms of Parkinson's, which we call off time, or are you more bothered by the side effect of the medication, like the dyskinesia? And the vast majority of people are more bothered by the off time or the symptoms of Parkinson's than they are by the dyskinesia or the complication of the medication. Some people will be on levodopa and not have the typical experience. The typical experience is a good, robust effect, a response to the levodopa that's noticeable and beneficial. So some people will say, why isn't it working that way for me? So various reasons. The dose could be too low. That could be a reason why you're not noticing the benefits. Could be that the symptom that you're bothered by or that you're focused on is a symptom that's not as responsive to levodopa for you. For instance, maybe the levodopa is helping stiffness and slowness, but you're really bothered by your walking, and maybe your walking is not responding as well to the levodopa. Or maybe you have a non-movement symptom that's bothering you, like fatigue. And for some people, the fatigue responds to levodopa, but for you, the fatigue is not as responsive to levodopa because it's being caused by bad sleep at night. So there's various reasons why it might not be as noticeable. It's possible that you're not absorbing it well. Levodopa is absorbed in the GI tract, in the gastrointestinal tract, differently in different people. And the gastrointestinal system is moving differently for different people, and even on different days, it may be working differently. So you may not be absorbing the medication efficiently. It's possible you don't have classic Parkinson's disease. Classic Parkinson's disease, and one of the criteria for the disease is a robust response to levodopa. And for some people, not having a response at a good dose of levodopa may suggest that there's something atypical about their Parkinson's diagnosis. And then it could be that the duration of the effect is just too short, or the threshold for you for side effects is lower than typical. And so your brain is not handling it as smoothly as is average. The average person can tolerate X amount of levodopa without any problems tolerating it. And for you, your brain just doesn't tolerate it as well. And that could be why you're not able to get to a dose that's working for you. So again, that speaks to the variability from person to person. What we see over time as Parkinson's progresses, I mentioned what I consider mild disease is a response to levodopa that is smooth and balanced and comfortable. And as the disease gets a little bit more advanced, one of the criteria that I use to call it a little bit more moderate or more advanced is that response to levodopa becomes sort of shorter and less efficient. So there is still a response. There will always be a response for the majority of people. It's just that response, as the disease gets more advanced, gets shorter, and the threshold for getting the side effects becomes lower, becomes easier, and the threshold for getting benefits becomes higher. And so what you start to see is this the inefficiency of the medication. Carbidopa levodopa in the form of Sinemet actually lasts a very short time in our bodies. The half-life of Sinemet is 90 minutes, which means that after 90 minutes, half of it is gone. And so it's a very short-living medication, which explains why for some people, the need to intake it more and more frequently happens over time, especially as the brain does a worse job handling the medication as the disease progresses. So what we naturally end up seeing is that we need to give it more and more often. But as we give it more and more often, that means we may be giving more medication, which can lead to some side effects. So how do we deal with that? as we start to see these ups and downs in that people have the medication wearing off on them, and so their Parkinson's symptoms return. We call that off time. On the upside, when their medication is working, it may be working too well, and they may be getting fidgeting or dyskinesia. And so, how do we deal with these ups and downs as the disease progresses? Well, one option is we can try to improve the off time or improve the Parkinson's symptoms without worsening the dyskinesia. And we can do that by fractionating. And what that means is something like if I'm having someone on 2 pills of carbidopa levodopa 4 times a day, and it's wearing off on them too much, but I want to keep the amount, I want to keep them from having to take more medication. Maybe I'll try going to 5 times a day, but lowering it to 1.5 pills. So instead of 2 pills 4 times a day, I might try something like 1.5 pills 5 times a day. And then the intervals are shorter, but the overall amount that they're taking in the day, I'm trying to keep fairly consistent. I might switch to a longer acting formulation of levodopa. And there are other formulations that you may have heard of, like Rytary or Crexont. These are forms that have both immediate and longer acting or delayed release, all in one form of carbidopa levodopa. And that can help improve the duration of the effect without necessarily worsening the dyskinesia. Or I might suggest avoiding food interactions to improve the absorption or to make the medication last longer. Another option is I can try to improve the off time or improve the Parkinson's symptoms with accepting that I might increase the dyskinesia on the other end. And for that, I can add in medications that boost the duration or the effect of the levodopa, the result of which could mean sometimes being on the upper end and having a little bit more dyskinesia if that's tolerable to that person. That can mean adding a dopamine agonist or adding an MAO-B inhibitor or a COMT inhibitor or an A2A antagonist in addition to the carbidopa levodopa to make it last longer, to slow its breakdown, and to make it more powerful. Can also do unscheduled things like on-demand therapies. There's an inhaled form of levodopa that can be used just as needed. There's an injectable form of a dopamine agonist called apomorphine, which can be injected into the muscle as needed. These are options for people who just need occasional boosts or occasional return of their control of their symptoms without necessarily something added scheduled into their day. And then there's the potential to improve the off time while also reducing the dyskinesia, which sounds like the best of both worlds. There's really only one medication that's approved to do both of those, and that's the amantadine or amantadine extended release formulation, which has a brand name. And as I mentioned, this is helpful for many people, but it's not for everybody, because especially in people who are older, who have cognitive impairment or have hallucinations, we do have to watch for some side effect potential for hallucinations and cognitive side effects in some of those older folks. So then, beyond the medication adjustments that I kind of just covered very broadly, what we really want to do is take these ups and downs, these, as you can see, this kind of windy up and down road, and make it flat and make it smooth and make it even. Um, and so if those oral medication options are exhausted, and there are a lot of oral medication options, I didn't really cover them fully, just gave you a flavor for them. What do you do next if all of that has been explored or exhausted, or if someone's not a good candidate for some of those options? Well, in someone with more advanced disease who's having a lot of these fluctuations, we have more advanced therapy options, which can include delivering continuous levodopa directly into the gut through a pump. And that's the Duopa or Duodopa pump that has been around for several years now. That is a surgically placed pump that goes directly into the gut, and the levodopa is infused directly into the gut 24/7. And so it gives a continuous delivery without these ups and downs. More recently, we've had through the skin or subcutaneous ways of delivering medication, both a form of levodopa and a form of a dopamine agonist called apomorphine, which can be delivered instead of surgically through the gut, using a device that almost looks like a patch that is delivering the medication through the skin continuously, as a way of delivering medication throughout the day and even throughout the night in some cases, without having to take these ups and downs with pulses of medication throughout the day. So these are new options for people with more advanced symptoms. And so just to take a deeper dive into one of those, this is an example of the through the skin form of the levodopa pump. It's a phoscarbidopa phoslevodopa pump that's delivered through the skin. And this was approved about a year ago. And what we see here is in the studies, it showed an improvement of about almost 3 hours of improved off time. That means better control of Parkinson's symptoms throughout the day by nearly 3 hours compared to oral levodopa, and nearly 4 hour improvement in the medication working without bothersome dyskinesia. And there was improvement in feeling control in the morning when someone woke up, which is unusual because usually in the morning you have to wait for your oral medications to kick in. But if someone's on a continuous pump that's working through the night, they can wake up with the medication already working. So this is something that's available for people with advanced Parkinson's disease who have bothersome wearing off symptoms, initially with private insurance, but now recently starting to get Medicare approval as well. Um, what to be aware of with this, though? It is a bit of a lifestyle change. This is not as simple as it sounds. While it is delivering medication continuously, it does require training. There are home nursing visits. It requires a commitment to good skin care, to managing the device and the pump. Skin irritation and skin infections are possible with this, and that is something that needs to be watched for and monitored for closely. The pump needs to be carried on you at all times and filled with medication. And it can require, depending on how your clinician does it, it can require a lengthy initiation session to figure out the right settings and dosage. And while today's session was really meant to be talking about medication, so I'm not going to be talking about surgery too much. I do want to cover that there are options beyond medications for dealing with more advanced symptoms because I want to cover the breadth of the disease. And in more advanced symptoms, we also have surgical options like deep brain stimulation and focused ultrasound. For people who either are having tolerability issues with medications or are exhausting what they can do with medications because they're hitting side effect limitations of medications, or their medications are having to be taken in a way that's not really feasible. And so this is for someone with Parkinson's disease who responds to levodopa, but that response is not smooth enough or is limited by some side effect. It is not a good option for patients who have dementia because it is brain surgery. We don't want to do brain surgery in people with dementia. We can sometimes see worsening cognitive problems when we do that. The goal is often to reduce the amount of medication that someone has to take, but maintain the same benefit of medication while being able to take less of it and kind of smooth out that bumpy road that I described. Focused ultrasound, on the other hand, as opposed to deep brain stimulation, is a newer procedure where it's right now it's approved to treat tremor on one side of the body, tremor related to Parkinson's disease or tremor related to a benign essential tremor. It requires having a specific skull thickness that can be measured on a special CT scan, and it can be used to reduce tremor specifically. For now, that is the main indication for it, although that may change in the future. So as we compare these two surgical options, deep brain stimulation is an actual surgery, physical surgery, whereas focused ultrasound has no cutting. There is still a lesion that's being made by it, but it's not with any incision. It's incisionless. DBS has a device that's implanted, whereas with focused ultrasound, there's no device that needs to be implanted. However, focused ultrasound is not adjustable or reversible, whereas a deep brain stimulator is adjustable and reversible. We know more about the long-term benefits of deep brain stimulation because we've been doing it for like 50 years, whereas with focused ultrasound, it's newer, and so we know less about the long-term effects. With deep brain stimulation, we're approved to do both sides and more than just target tremor. It can target the slowness and stiffness as well. Whereas with focused ultrasound, currently it's approved for one side as tremor as the target. Um, And so that kind of is an overview of what we do practically with medications and surgery. And then we have to realize that can't treat the whole disease. I showed you that puzzle of the disease, and not everything responds to medication or to the dopamine focused medications. We find that sometimes even some movement symptoms don't respond always to just dopamine medication. So tremor, for some people, will respond to the medications we talked about. But for some people, tremor is really stubborn. And sometimes they don't get the relief they want from medication. And in which case, surgery like deep brain stimulation and focused ultrasound can actually help with tremor. For some people, balance issues and freezing of gait, where the feet kind of get stuck and don't want to move, sometimes that does respond to the medications I talked about, but I do see that as the disease advances in some people, balance issues and freezing can sometimes become an issue that doesn't respond as well to medications. In which case, we have to think about physical interventions, things like exercise and balance training, and thinking out of the box, things like Tai Chi and dance and physical therapy and using devices that have lasers that can be used as cues to help with freezing and to reduce falls. So we kind of have to think a little bit outside of just the medication box for things like that. Dopamine is only part of the story. And that's another reason we have to think outside of the box. We have to think in people with Parkinson's, while we focus a lot on dopamine, norepinephrine and serotonin, which are other chemicals, are also impacted in Parkinson's disease. And you can see there's a overlap here of effects on things like mood and energy and different symptoms that we know are common in Parkinson's that could be related to other chemicals beyond just dopamine. And so if we look at how common these non-movement symptoms are, they are common. We talk about them every day in our clinics. And again, it's not everybody that gets all of these problems, but some combination of this is common and to different degrees in different people. We deal with mood problems like anxiety and depression, autonomic problems like blood pressure drops that lead to dizziness, cognitive issues, fatigue is really common. I have percentages here as how common these are in different surveys and studies. You can see most of these are seen in up to a third of people. So really common sleep problems, urinary problems. You can see the whole combination of different things. So we need to address these as well. And dopamine alone doesn't typically do this, but it can have a role in some cases. Sometimes dopamine can be the opposite problem with some of these non-motor issues. And sometimes it's a tug of war trying to address one issue and not hurt another. And so, for instance, I might want to raise dopamine with more levodopa to try to treat things like tremor, dexterity, stiffness, and mobility. But I might want to lower the levodopa or the dopamine medications if someone's experiencing things like hallucinations or confusion or low blood pressure. And so sometimes I have to find which is more important to treat. And if someone's having hallucinations or confusion, even if they're having tremors, I might want to actually lower their medication to address some of these non-motor issues. And so finding the right balance is one thing that you have to work with your doctor on. And then non-motor issues can be treated separately too. So if someone has mood issues, we do use SSRIs and drugs like mirtazapine. These are typical mood medications. What we don't use is antipsychotic medications as much because those can block dopamine. We use counseling, we use exercise and mind-body activities to try to address this. And then sometimes Parkinson's medications can help mood in some people. Depression, anxiety sometimes responds, but if it doesn't, then we need to think about some of these other options. Autonomics, this is things like blood pressure drops and being lightheaded. Sometimes these can be worsened by Parkinson's medications, in which case we may have to pull back on them, or we may have to treat with other interventions like having more salt and hydration, compression stockings. Sometimes we have to treat with medications like midodrine or fludrocortisone or droxidopa to raise blood pressure. And then there are other symptoms that are common in Parkinson's that also fall into this category: drooling and runny nose and sweating, erectile dysfunction and constipation. These are all part of the autonomic nervous system. All can be affected by Parkinson's and don't necessarily respond to levodopa or dopamine medications and need to be treated separately. Sleep and fatigue, very common. Sometimes Parkinson's medications can help these symptoms. But again, if they don't, then we need to think about are there other ways to treat these? Sleep hygiene and cognitive behavioral therapy. And I've listed some medications here that we'll often use for different sleep issues, but it depends on what the sleep problem is. So the first step is trying to understand better what is the sleep problem. And then cognition, hallucinations, those can be worsened by Parkinson's medications in some people. We may need to lower the Parkinson's medications if these are becoming more problematic. And then we may need to address them with medications like donepezil or rivastigmine. If there's hallucinations, we can't use most antipsychotics, but we can use drugs like pimavanserin, quetiapine, clozapine, and then again, exercise, mental and physical activities can actually help with this. And if someone's developing impulse control issues, I mentioned up to 13% of people on dopamine agonists, we may need to slowly lower the medication to reduce the risk that someone could have into their social life. And so when you put it this way, of all these motor symptoms and all these non-motor symptoms and finding the balance between them, and we have to individualize our treatment plan, one thing that is useful for everybody is mind-body activities, because mind-body activities will help with both the motor and the non-motor together. And by themselves is not enough. They don't replace medication, but they can really help, and they can really, they're unique in the fact that they can target both the movement and the non-movement symptoms at the same time. And that can include whatever you enjoy in terms of mind-body, Tai Chi, yoga, dance, improv, therapy, artistic expression, boxing, physical therapy, and other things that I've listed, that I've shown here. So I really encourage you to engage in these non-pharmacological therapies because they're safe and they can treat, all aspects of the disease. And I've listed several of those here that we often recommend for people as part of a healthy lifestyle too. So I often give people this exercise prescription. If you've been to any Parkinson's talk, you've probably heard about the importance of exercise in treating both the mind and the body, and treating both the movement and the non-movement symptoms. And this is just a general template: aerobic activity, strength building activity, balance training, all important in people with Parkinson's disease. This is from a study from about 10 years ago from, I think, Finland, that showed that the combination of diet, exercise, cognitive training, and reducing vascular risk factors was overall predictive of better cognitive function over time in elderly people. So if you want to protect yourself against cognitive decline, doing all these healthy lifestyle things can actually make you less likely to get cognitive problems over time, which is already a risk factor with Parkinson's disease. When you're looking for exercise programs, you want goal-based practice for acquiring a new skill because that will help you physically, but also help you mentally to learn a new skill. Ideally, you want a supervised environment where you're learning through reinforcement, something enjoyable that you'll keep up with, something social. You want instructors who understand Parkinson's disease. You want to find appropriate level classes for your abilities. You also want to think about counseling and support groups. You want to think about your mental health and your physical health. Sleep hygiene. I can't tell you how many people will tell me that if they have a good night's sleep, their physical symptoms are better the next day. If they had bad sleep, they don't function well physically the next day. It really matters. Your mental health matters. General medical well-being and general medical checkups matter too, because if you're unhealthy for other reasons, your Parkinson's symptoms will suffer too. And so jumping on to some of these just general medical issues that are tied into Parkinson's, we can treat these. We can treat these separately, whether it's sleep or blood pressure, constipation or sleepiness. We want to address these if there's a problem, but it's not always with just medications. And so this is not meant for you to read all of this, but as an example, in our clinic, we'll give out informational sheets about constipation or about sleep hygiene or about managing low blood pressure or orthostatic hypotension. And the Parkinson Foundation also has a lot of good information on their website that is how you can address many of these common issues. So I'm going to wrap up here so that we can take some questions. But Parkinson's disease is individualized. It is different for everyone, and it includes a combination of motor and non-motor symptoms that will respond differently to treatment. There are a lot of treatments in our arsenal, but they're going to be used differently from person to person. Levodopa is the gold standard for managing the motor symptoms. The data supports that. Our experience for decades with it supports that. It is turned into dopamine. There are complications as the disease progresses and as time passes that are related to motor fluctuations, the ups and downs, the dyskinesias on the ups and the wearing off on the downs. And there are a lot of strategies that we can use to address that. And there are advanced therapies, including surgical therapies and infusions now, that can be used to address these motor fluctuations now also. And so those options are growing. But all medical and surgical options have their pros and cons that need to be individually weighed with you and your family and your doctor weighing in individually on what the benefits or side effects would be for you. And many symptoms do require thinking beyond just dopamine. It's not that simple of a disease, as you saw from that complicated puzzle of symptoms. So the solution can't be that simple either. And in some cases, there's a trade-off between managing the movement symptoms and the consequences of the non-movement symptoms. And so that tug of war and trying to find the right balance. And then non-medication options and lifestyle-focused interventions are a non-negotiable, in my opinion. I think they're valuable in Parkinson's. They're safe. They are standard of care. And that includes everything from healthy eating to exercise, mind-body activities, mental health, good sleep, diet, all of that. And so with that, hopefully didn't overwhelm you. I thank you for your attention. And we're gonna, I think, shift gears into some question and answers.
That's right. Thanks very much, Dr. Bega. This was a really fascinating overview of the many medications that are available for people with Parkinson's disease. And I just want to address the elephant in the room that's out there. And one of our listeners, Eduardo, asked this question, and this is something I'm sure you hear a lot from your patient community. The medications you've been discussing, levodopa, they have a long history. They've been around for a long time. Um, what's do you think is new on the corner? I know you're involved in clinical trials. Is there hope that we're not going to just this is not going to be the status quo, that we'll be looking at some new medications in the future?
Yes, I get the question a lot about like levodopa. Everyone seems to realize levodopa has been around for a very long time. I mean, if you've actually seen, I really like the movie Awakenings. It actually shows some of the initial uses of levodopa back. I want to say that was like the 1940s or 1950s, I think. And we're still using it. And so people are like, why have we not gone beyond that? Why are we still using this drug from like 1950s? Well, first of all, just realize the reason is because it is that good. In that levodopa is turned into dopamine. It is the precursor to dopamine that our bodies make, and it's a synthetic form of that we're turning into dopamine. And so we know that a lot of the symptoms do respond to replenishing the dopamine. And so we're always going to be focused on for symptom treatment. We're always going to be focused on how do we get dopamine into the brain as efficiently as possible? So when we look at what's advanced, though, there have been a lot of advances in dopamine, in levodopa. And what you're seeing as advances are more efficient ways of delivering it, more efficient ways of absorbing it, more ways of kind of reproducing what our brains are naturally trying to do, of slow, continuous release of dopamine rather than these like random pulses of dopamine. And that's where the advances have really come along in the last decade with these new long-acting formulations and now the subcutaneous formulations, and that's where we've seen progress. What we would like to see, the problem is that we're not treating the disease with levodopa. We're not treating the underlying cause. We're not slowing it down. We're not stopping it. We're really focusing on symptoms. And so what we're seeing where the research is focusing on, and we didn't talk about research at all today, but where the research is what can we do to actually get at the mechanism of the disease and slow it down? And where I'm excited, I see this as kind of a few branch points. We're looking at the genetics of, and you talked about PD generation and why that's so important. We know if we can target something, then we might be able to slow it down. And so if we can find out who has these genetic markers, maybe we can target those genetic markers with future treatments to try to actually slow down the disease progression. We know that the protein that builds up in the brain, which I didn't mention the name, is called alpha-synuclein. That protein builds up in the brain in people with Parkinson's, and we think it's part of the damage that's caused in the disease is related to that protein buildup. And so some companies right now are aggressively working on trying to block that protein, try to prevent it from building up in the brain or try to clear it. And so that we're really hopeful. There has been some positive progress in that area of trying to slow down the disease by targeting the protein from building up. So I'm very excited about that as well. Stem cells is another kind of a third category where can we regrow, can we regenerate dopamine producing neurons in the brain instead of having to take medication? Can we just kind of fix the factory itself so the factory starts making the dopamine in the brain again? And that's also another area that's starting up now in kind of early phases of research. So I'm very excited about all of those as potential, but unfortunately we have to be patient. And if you're living with Parkinson's, it's easy for me to say be patient. You can't be patient when you're living with it. And so it's really frustrating how slow this moves, and we get that, and we want it to move along fast, but these trials do take time, unfortunately.
Agreed. Yeah, for certain, we definitely feel the sense of urgency from the community. So thank you for that answer. Um, and another question, I think you touched on this a little bit coming through here is, just a broad, I think one, how do people with Parkinson's get the maximum benefit from their medications? I mean, is there a simple way with which for them to really achieve the benefit from you as a prescriber, giving this, here's the medication I want you to take. What advice do you give to your
Yeah.
patients?
I think there are ways to optimize it. So one is it is really um, important to take it as prescribed and then adjust from there. The reason I say that is I have people who struggle with the medication and they start to kind of do their own thing a little bit with it, take it a little bit randomly, miss doses, or they try to like fine tune when they think they should take it and they kind of adjust their schedule. And the problem with that, not that we don't want you engaged in your care, we do want you engaged in your care. It's that it's really hard to understand what the medication is doing when it's being taken kind of differently each day. And the best thing we can do is be predictable and consistent and then adjust to fix the problem. And so if someone is thinking their medication is not working well, the best thing they can do is take it exactly at the same as prescribed at the right times, keep a diary. I took it at, 8 in the morning, at 1 p.m. and at, 7 p.m. And I noticed that it's doing this at this time and it's doing that at that time. And that's what I'm not liking about it. And it's consistent. And then they can bring that information to me and I can go, okay, I see where the problem is. I can adjust it. Let's adjust it based on that. But if someone's just doing it randomly and differently each day, it's really hard for me to know if they're having a side effect or if they're having inadequate benefit and where to adjust it. So that's one. So talk to your doctor and work with them, but try to keep track and be consistent. Number two is like how and when you take your medication. In particular with levodopa, it can really matter. I mentioned the GI absorption issues and how well it's absorbed will be why some people say a dose worked and another dose didn't work, or one day was good and another day was bad. It could be related to your absorption. And so some tips and tricks we usually recommend if you're able to tolerate it on an empty stomach, we do think the absorption may improve, may be better, it may last longer, it may kick in better if it's taken away from food. Now, the challenge is some people get nauseous if they take it on an empty stomach. And so for those people, they have to take it with a little bit of food. And in those cases, trying to avoid protein with the medication can still be helpful. Taking it with some crackers, some toast, but not with protein, because it's proteins and fats that will sometimes compete with the medication for absorption. And so trying to time it in a way that is favorable for your absorption, talking to your doctor about how to troubleshoot for you personally. And we even have involved dietitians in this because I have some people who say, I take my medication 5, 6 times a day. How do I avoid protein or meals with my medication? And so, working with our dietitians, we've been able to help people come up with meal plan strategies for how to optimize that with their day because you still need to have a normal diet and protein in your diet. So things like that can help.
Yeah, fantastic. So it seems taking your medications on time, that's a good start. And then and be consistent if you do making adjustments so that you and your physician can do the troubleshooting to make those adjustments as part of it. You know, uh, what we've heard, and just like I know you mentioned it briefly in our talk, is and some of the questions coming in have talked about this too. Maya, one of our listeners, is this issue of and misconception. It may still be out there that carbidopa, levodopa should be reserved, and its effect because its effect wears off over time. I think you hit it when you described it. It's really the brain changes that are happening. So it's the disease progressing. It's not that the medication is changing. It's how your body really processes it. Is that an accurate way to describe it?
Yeah, so I specifically had that slide about it because over 10 to 15 years of practice, it's the most common question I get from newly diagnosed patients or patients who are, not yet on medication is, they're worried about starting it. And I get it. Like, you have this medication that we're telling you is the gold standard. You don't want to waste the gold and, not have it for later. And it like logically makes sense because also what you see is over time, you see people that are not responding as quite as well as they did early on. So the brain, our interpretation of that is it's sort of building a tolerance or something like that. And so that's why I kind of have that is I think it's really important to realize we know for sure that if someone needs it and they're delaying taking it, and when I say they need it because they're struggling in some way, their quality of life has gone down, they're not able to exercise as well because they're not on treatment, that period of time where someone would be on treatment versus not on treatment, there's a clear improvement in quality of life if you're on treatment during that time. Meaning, if you need symptoms and if you have symptoms and you're putting it off because you're worried about losing the benefit, you're clearly losing benefit during the time that you've been putting it off, and you're losing quality of life. And that time is important. It's just as important now as it is going to be later on. So I would remind patients of that. Don't suffer now because you're saving it for later. You should feel good now. You should be able to exercise now. You should be able to do the things you want to do now. You don't know what's going to happen later. The second thing is we know that it turns out that later, regardless, is going to be a more complicated time for most people, even if they delayed taking it. And that is because the brain changes. And we can't stop that yet. So as the brain changes and you've had Parkinson's for a longer period of time, that same levodopa just doesn't get handled as well. And so you may have put off taking it and now you've missed out on the smooth, good time with it. And now when you start it, you're already a little bit more advanced. You're going to kind of start to see it shift into those fluctuations naturally anyway. And so it can seem like you've sort of put it off without the benefit that you were hoping for. And you'll still see those fluctuations as the disease gets more advanced, unfortunately.
Yeah, for
So we
sure.
just deal with those fluctuations when they come.
Yeah, absolutely. And another just a question that's come in that's kind of interesting is that there are people out there who've had trouble with weight in the past and they've undergone gastric bypass surgery, which can fundamentally change how their GI system works. Have you had patients like that who've come through and have they had difficulty with dealing with the absorption of the levodopa? And would that be the kind of candidate you might consider for some of these, novel formulations, maybe subcutaneous forms?
Yes, I think gastric bypass and surgeries like it can certainly affect your gut motility and where your absorption occurs. And most of the absorption of levodopa happens in the first part of the small intestine, so like right after the stomach. And so it can still be absorbed, but seeing how things move faster or slower through your gut will affect the way you absorb medication. And so that may need to be adjusted after changes in your gut habits and after gastric bypass surgeries. And so, are there ways also to avoid the gut entirely? Is something that a lot of people ask about. Not just after gastric bypass, but if someone does have particularly bad constipation and they just know their pills are not getting absorbed well, and they've tried to manage it and they're not getting good absorption, can we try to bypass the gut? So, there's inhaled levodopa, which is not uh, a replacement for a baseline of medication. It's used as needed. But it is nice that that exists as a way to sort of not rely just on the gut. There's injected into the muscle dopamine agonist, which also doesn't rely as much on the gut. So those are two things that we have as needed options to kind of help people in between doses if they're having problems with gut absorption. But now we have this whole new world of subcutaneous infusions, which deliver the medication through the skin. And they're still new, and we're still evolving and learning it. But that is a potential option for people who are having issues with gut absorption. Is let's absorb the medication through the skin and get it more directly.
Fascinating. Related to that, I've got several questions coming in here about, upper limits of levodopa dosage and the idea of how soon does Cinnamate go into effect after taking it, and I'm just curious about different formulations on versus off time for levodopa, carbidopa. I guess what is your therapeutic approach when you see patients like this and the conversation you have with them clearly because you're involving them as part of this decision making. How do people you advise going from the immediate forms of release to these extended forms of release to these other um, you know the produodopa or the I can't remember the subcutaneous form of it. I mean, how do you counsel your patients and how's that interaction going? Is it really based upon their specific needs, controlling the motor symptoms specifically, or are they, are people traveling a lot and finding that like one form's better than the other? Because that's a question that comes into, and as you can appreciate, when people are traveling, everything kind of gets messed up, it seems. So a lot to there unpack, Dr. Bega, but I'm just curious to hear your thoughts.
The when we start carbidopa levodopa, typically we'll start Cinemat or which we think of as kind of the regular immediate release carbidopa levodopa. People early in Parkinson's do well with that as a 3 times a day medication and can usually manage that and get good kind of continuous relief with that. We always want, as a rule, we always want to use the least amount that we need to give someone the good quality of life, the good symptom control. Um, because higher doses are going to be more likely associated with more potential for side effects. So we always want with any medication, you always want to use the lowest amount that you need to see the benefits that you're looking for. I think what we start to see is over time, as we start to need to go to 4 times a day or beyond that, it starts to become difficult for people, and it's hard to keep on a schedule when you're having to take it 4 times or more. And that's often when, for me, that's often when I will start to think about switching to some of the longer acting formulations, the extended release formulations. Is if I'm going beyond 4 times a day, they can be used initially even as 3 times a day medications. Also, there's some cost differences and access differences that might affect that decision. But generally for me, I'm thinking about them more when I'm going to more than 3 times a day because of convenience and ease and, stability. And then I want to keep people as smooth as possible. I want to, I want to have minimal dyskinesia. Usually people are willing to accept some, and I want to have minimal wearing off. And so whatever I need to do to keep people in that kind of feeling even, that may mean adding in as needed inhaled levodopa. That might mean, again, switching to the longer acting formulations. But if I'm already on a complicated regimen, if I've added in medications to make the carbidopa levodopa last longer, and I'm on extended release formulations, and I'm still having issues with ups and downs, that's when we're starting to have a different discussion, what we call advanced therapies. That's when we're starting to introduce things like deep brain stimulation or subcutaneous infusions or things like that to try to smooth things out. Um, I think that it kind of hopefully that answers that question.
It does. Thank you very much, Dr. Bega. And I think we're at time, and so I want to thank you for your time and sharing your insights with us today. It's been really fantastic on talking about medications for Parkinson's disease. So, and I want to thank everyone out there who joined us today. Unfortunately, we weren't able to get to everyone's question. There are a lot coming into the Q&A. I know if you have questions that weren't answered, our helpline can certainly be there to help as part of that. Please feel free to call 1-800-4PD-INFO as part of that. I would also like to thank our sponsor, UCB. They are supporting our mission at the Parkinson's Foundation through a generous unrestricted educational grant to support our expert briefing series. And here is an outline of what's to come. Our next session is going to be Wednesday, October 15th. So we've almost to the finish line for the year for expert briefings. And it's going to be a very easy thing to talk about improving gait and how to maintain steady steps. So I encourage everyone who may have that as a concern or just interested, please join us on that date. And you can also learn more about future topics at our webpage listed there on the screen as well. I also want to highlight that we have a weekly virtual program in addition to the one we're hosting right now, Mindfulness Mondays, Wellness Wednesdays, our Fitness Fridays, and then we also have our sessions in Spanish as well. So please feel free to visit parkinsons.org health for more information and how to register. Before you go, I just want to let you know we're here for you through our helpline website and helpline email address, helpline@parkinson.org. So feel free to check those out. And also, before we depart, we're in the realm of Zoom. The screen will go black, and then a survey will pop up on your screen. So please feel free to fill that out. We really value your input and use that to guide our future expert briefings, provide feedback to our presenters, and always keep in consideration what we're doing is aligned with the needs and priorities of those living with Parkinson's disease. So until next time, until October, take care, and we'll see you at the next expert briefings.